And I'm going to start with an apology. I do have a revolting cold, so it's a good job that I am this far away from you all, and I'm not being my usual friendly self and being very involved with everyone, so apologies for that too. And if I end up having a coughing fit, then Emily, you're going to have to take over. So the title of the talk today is around getting treatments to our community, and it's the work that we've been doing on Project Hercules. Just to give you a bit of background into who I am, so this is Fleur and this is my son Dom. Dom was diagnosed with Duchenne when he was 3, so that was back in 2009, so I've lived with Duchenne in our family for the last 15, 16 years. He's now 18, he's 19 in a couple of weeks, and living away at university. He's doing a BSc in computer games design. He loves music, he loves concerts, he loves films, he loves computer games, and also he was in a clinical trial from 2015 to 2017. The other person in that photo is me, his mum, and was his primary carer. My professional background is a health economist and market access specialist, excuse me, with 30 years plus in pharma, mostly in market access and health economics. So I was head of market access UK and Ireland at Sanofi and head of respiratory global health outcomes at GSK. And that is all around making sure you've got the right evidence to get access for medicines. And founded Project Hercules with Emily and Josie, which I'll talk about in a bit. So you've probably heard a lot about the drug development process, but what I'm going to be talking about is a very specific part of that. Thank you, Emily. Yeah. Yeah, so the drug development process we've talked about a lot. What we're going to talk about today is the piece called the HTA process, or the Health Technology Assessment process. So as your medicine goes through its development, you go through discovery, you go through preclinical. We've heard a lot about these things. Clinical horizon scanning is when all the agencies start to look to see what's coming. Marketing authorization is the regulatory element to it. And then the HTA process is around how people judge whether it's worth bringing that to that market. And it's really important because unless you get a positive health technology assessment done, the medicine won't reach patients. So what are the sort of evidence requirements that we're looking for in those 3 different areas? So the regulators, they are looking for whether the treatment is safe, whether it works or not, whether you can consistently create that molecule to a significantly high standard and high quality. The payers at the other end are looking for, is it good value for money? Is it affordable? And if we pay for this medicine, then what are we going to not pay for? Because budgets are not endless. So what health technology assessment does in the middle is a very methodological approach, and it works out, so how effective is this medicine? How cost effective is it? And does it fit into the healthcare system? And there are very strict rules and ways of doing these health technology assessments. And they will then give the evidence to the payers to decide whether they want to actually bring it into their healthcare system. So you need evidence for this health technology assessment piece, but it's not just at that particular point. You need that evidence from across the whole disease and across the whole development side. So what we wanted to do with Hercules was take a collaborative approach. So what do you actually need for an HTA? And I've done so many of these, and I went to the World Duchenne Organization conference and spoke with a professor of health economics who described them as the world's most boring book, which is bit distressing, having created God knows how many of these world's most boring books. But basically, the HTA submission needs to cover a disease model of the natural history, an understanding of what's going on currently, data on how much the illness costs, systematic reviews, which are extremely boring and very expensive, of the evidence on what the comparator treatment would look like, what the utility is. Utility is a very specific way of measuring quality of life. Excuse me. Resource use and burden of disease data. You need evidence to fill any gaps that are there. An economic model which predicts out how much if you introduce this technology, then what difference will it make to the costs of the disease? And then all this needs to be published. So in a standard disease, where if you're working, say, asthma, for example, this is relatively easy to do. So you get all the information, there's plenty of patients to go and ask, there's lots of already recognised measures and evidence generations and databases. So for something like asthma, for example, it's relatively easy. It's not cheap, it's relatively easy. For something like Duchenne, it's very difficult because there aren't so many patients to ask. You've got multiple companies all asking the same things, and you've got you don't know what the long-term progression is as they're changing and moving along. So taking a collaborative approach was what we decided to do. So HERCULES, we're dropping the project. It's no longer a project, it's a thing. Is a unique global collaboration. So the idea came from myself and Emily to start with, and then we brought in Josie Godfrey. Josie is extremely experienced in health technology assessment. She set up the HST at NICE when she worked there, and in its predecessor, the Agnes process, very, very experienced in access in rare diseases. There's myself, who's got the pharmaceutical experience, plus the son. And Emily obviously invested at risk in what was particularly a risky project at the beginning, because she saw the value of it. Because like what Emily said to me at the beginning very much was, there is something worse than having no treatments, and that's having treatments that no one will pay for. And what HERCULES is trying to do is give companies the evidence that they can use to make sure that that decision is much easier. So when I say it's a unique collaboration, you can see just how unique this is. So not only are we working with the companies who are providing working on the clinical trials and providing the evidence, but we're working with the decision makers as well. So NICE have always been part of the HERCULES steering committee. And then we have multiple universities, academics that we like to bring in as well. So how does it work? So I mentioned that in your HTA you need a certain number of things. So what we're trying to do is create a disease-level, pre-competitive evidence base. It's run by a steering group. So what we've provided so far is an economic model that's been reviewed by NICE and have said that they had no comments, which is absolutely unheard of in my 30-year career. Patient quality of life, excuse me, the carer quality of life, burden of illness, CPRD study, steroid impact, and natural history. Excuse me. You braced, Emily. I think I'm all right. So in our first phase of HERCULES, created 4 outputs, so a DMD natural history model, the DMD qual, an economic model, and a burden of illness study. Just to go through these quickly, because I don't have much time. The natural history model, what it used to look like was this. It was early ambulatory, late ambulatory, early non-ambulatory, and then late non-ambulatory. We realised that there were different stages that would be useful in this. So we've included what's now called the transfer state, because it's really important to be able to weight bear, and that wasn't really measured before. So the transfer state we've included. Excuse me. And in the non-ambulatory state, we're looking at whether patients are ventilated, whether they have hand-to-mouth function, whether it's nighttime ventilation or full ventilation, and breaking down those non-ambulatory states into some different ones which are important. So all of these states are important not to get to. That's the point. What we're trying to say is that when you bring an intervention in, you will not progress as quickly to these other states, which are therefore costly and impactful on quality of life. The economic model, as I said, has been tested and works well. Quality of life in DMD, the usual quality of life questionnaire is something called the EQ5D. We assessed it, it didn't work, so created a whole new one. Which is now translated into, it's going to translate into 30 different languages. So useful, and it's not just informing health technology assessment, but it's also informing clinical practice. Burden of illness is another big project that we need to look at. So if you treat Duchenne, then what are you avoiding? What does that burden look like? This is quite an old photo, but we've now got 14 companies, or have had 14 companies involved in HERCULES. And recent feedback was that it was the easiest submission that they've ever had to write. Our current objectives, we need to start looking at upper body mobility and function. That's our ATLAS project. We need to be linking clinical measurements to long-term progressions and outcome. Oh, excuse me. Carer quality of life, understanding paediatric evidence, disability impact, and there's another one that I've forgotten. Burden, that's it. What we're trying to do is educate and inform people what we've been up to with Hercules, and hopefully within my spluttering you've managed to achieve some of that. So these are the sorts of things that we're doing with Hercules. It is a groundbreaking project. I am so proud of it. I'm so proud of Duchenne UK for backing it, because it seemed like a stupid idea at the beginning, but actually has turned out to be a really, really good one.